So a summary of the changes that happen, right, so like changes in PKPD and renal dysfunction. So absorption, up, down, or unchanged, we don't know. Distribution, up, down, or unchanged, we don't know. But what we do know is that protein binding goes down, right? So protein binding definitely goes down due to low albumin concentrations and uremic toxins that compete for protein binding sites. So that is one change in volume distribution that's important that impacts therapies like phenytoin. Metabolism, there's a reduction in phase 1 metabolism. Those are all of your CYP enzymes. Okay? Phase 2 metabolism stays unchanged, which is important because those products of phase 2 metabolism get eliminated by the kidneys. So glucuronide, sulfide, those metabolites, which is a conjugation reaction, those then get marked for renal excretion. Okay, so those glucuronide metabolites can accumulate, like with morphine glucuronides, and that can cause some side effects. And then elimination should be evident that renal elimination will be reduced proportional to the GFR. So those are the main changes. PD changes. There's increased permeability at the blood-brain barrier, so more CNS side effects of drugs. There is decreased platelet aggregation because of those uremic toxins sit on some of those platelet aggregation sites and prevent them from sticking together, so there's increased bleeding risk. Some drugs like calcium channel blockers or beta blockers, the receptor sensitivity goes up, but those are more kind of specific situations. The blood-brain barrier, the platelet aggregation, those are the big ones that affect a lot of drugs across the board. Opioids, morphine and meperidine are avoided in late stage CKD and end stage. The ones that are safe are fentanyl and methadone. They just aren't often used because of clinical familiarity or kinetic profiles. Like fentanyl has very short half-life. So the ones that kind of fall in the yellow zone, right in the middle, are oxycodone, hydrocodone, and hydromorphone. And those ones are safe to use, but should be used with some caution. List of antimicrobial agents that do not require renal dose adjustment. Good to know, not something I'm going to test you on. But yeah. So phenytoin, really what it does is it changes the way we interpret the corrected phenytoin concentration because there's less protein binding to the more free drug relative to the total concentration. So again, this is an equation that I would give you. I wouldn't expect you to have memorized it unless you know how to use it, and then interpret the results. If the target is 10 to 20, the result becomes in that range, the patient's doing just fine. If it's higher or lower, then the patient needs dose adjustment. Anticoagulants, we've learned a lot about this semester. Yeah. Yeah. So when treating an infection, it's important to know what antibiotics might be very hydrophilic, like the ones listed here. So these at the bottom may actually require a higher loading dose, so just the initial loading dose should be higher in patients that might have volume overload related to AKI or other disease states, because they're distributing to that water space. And if there's more water on board, you may need a higher dose. And that's in maybe like a severely sick or severe sepsis patient. So it's a critically ill patient. It's a very specialized population, but it's a kinetically based dose. So that's important to know because the volume of distribution is what dictates your loading dose. So that should be increased in patients that are getting hydrophilic antibiotics. Again, just that first dose. Maintenance dosing is then dictated by the clearance, which is renal function. So that's a bit more straightforward. Does that answer your question? Yeah, I mean, so you have to always weigh the risk of efficacy failure with the risk of toxicity, and a severe infection, the risk of aspistic failure is mortality. And so, like the example just that we did with vancomycin dosing, we calculated the dose of 896, so do you pick 1,000 or 750? Well, I pick 1,000 because I'd rather treat the infection and risk something like autotoxicity, which is bad, but still better than death from infection. So that's why I picked the higher dose. But that's also early in therapy in a very sick patient, right? So then as that patient recovers, then I might start picking lower doses because they've been responding well to therapy. Anticoagulants, your bleeding risk goes up because of the PD effects, but also many of them are dose-adjusted renal dysfunction, as we talked about in various classes with Drs. Samet, Mills, and Riley, right? All the new ones require dose adjustments. Warfarin, Argatrogen, and heparin are the only ones that don't require dose adjustments for renal dysfunction. So it's easier to remember that way. And then DIG is kind of a unique one because there's changes in the distribution and the elimination, and so the volume of distribution goes down because the drug is not binding to those peripheral tissues as much. And so the volume of distribution contracts, which means that our loading dose goes down, again, about 50% proportional to the change in volume of distribution. The clearance also goes down because it is predominantly renally cleared, and so the dosing interval then goes up as well. So our doses are cut in half, and our dosing interval is doubled. So it's going to give about half the normal dose every other day as a maintenance dose. You'll get tested enough on antidiabetic stuff in 602. You'll see ACEs and NSAIDs for like the AKI thing.